Every beep, every curve, and every tiny fluctuation on the ventilator screen tells a story about your patient. But the question is, are you listening to what those waveforms are saying? Welcome back to the channel. In today's video, we are diving into one of the most crucial yet often overlooked aspect of mechanical ventilation, that is ventilator waveforms. Whether you're a medical student, resident, working in the ICU or emergency department, understanding these waveforms can literally change how you manage the patient in real time. We will break down each waveform and decode what they reveal about patient-ventilator interaction, lung compliance, resistance, and even life-threatening issues like auto-PEEP or patient-ventilator asynchrony. By the end of this video, you won't just see those waveforms, you will understand them. Let's get started with the basic ventilator waveforms. Mechanical ventilation is not just about setting numbers on the machine. It's about understanding the interaction between the patient and the ventilator. These waveforms or graphics visually represent this interaction. They show how pressure, volume, and flow change with time during a respiratory cycle. So let's see how this helps. First is they recognize mechanical problems like obstruction, air leak, or any disconnection in the ventilator. Next is they help to detect patient and ventilator asynchrony. It assesses lung mechanics, that is compliance and resistance. It identifies life-threatening complications early like pneumothorax or auto-PEEP. So let's understand these. These ventilator waveforms are termed as scalars, which we see on the ventilator screen. Scalars on conventional mechanical ventilators are representation of specific respiratory parameters over time. The three scalars that we commonly visualize are volume, pressure, flow plotted on a vertical y-axis against time plotted on the horizontal x-axis. So these are the three scalars that we see, that is pressure time, flow time, and volume time. So today basically we'll be discussing in detail about the scalars. The next ventilator graphics that are important to understand are the loops. These graphics are one of the two variables, either pressure or flow, plotted against the volume during a breath. So we'll be discussing about these loops, that is pressure volume loop and the flow volume loops. So starting with the scalars. So the first one that we'll discuss is pressure time scalar. This pressure time scalar, it basically gives us information about the patient's airway compliance. So this is where the x-axis is the time and the y-axis is the pressure. In a typical graphic displayed on the ventilator, the baseline pressure indicates the PEEP, which I'm showing it here. And the maximum pressure at the end of this curve is the PEEP, that is peak inspiratory pressure. Peak inspiratory pressure is the total pressure needed to deliver the breath. So this is the inspiratory phase. The peak inspiratory pressure is mathematically calculated by adding the pressure created by the airway resistance, the pressure related to the lung compliance, and the PEEP. Next, let's see what is plateau pressure. Plateau pressure is the pressure after the airflow is stopped. This is the pressure in the airway under static condition or when there is no airflow. This value is thought to represent the pressure at the alveolar level and is obtained by doing an inspiratory hold on the ventilator. It is best measured in volume control mode when compared to pressure control mode, but can be measured in both of it. PEEP is basically the pressure at the end of expiration. This is the expiratory phase. An additional parameter that can be measured in the pressure time scalar is the intrinsic PEEP. This is obtained by completing the expiratory hold maneuver on the ventilator. So these are the parameters that we see in a pressure time scalar. That is this. It starts from the PEEP, that is the baseline. Then as the pressure increases and the maximum pressure is the peak inspiratory pressure, then coming to the plateau pressure, that indicates pressure in the airway under static condition, and this is the expiratory phase where the graph again comes down to the baseline. So these are the parameters that we see on a pressure time scalar. So the graph differs based on the mode of ventilation. In a volume control mode, the graph shows a rising ramp pattern where our control variable is the volume and the dependent variable is the pressure. So pressure increases as the lung fills due to the airway resistance and compliance. In pressure control mode, the waveform is a square waveform, that is due to the constant pressure, wherein the control variable is the pressure. So the set pressure is maintained throughout the inspiration, and hence we get a square waveform in a pressure control mode. This is for the volume control mode. So this is the difference that we have to note based on the mode of the ventilation. Next, coming on to the interpretation that we have to observe, where if the patient has a higher PEEP, that is a higher peak inspiratory, and a normal PEEP plateau, there the reason would be due to the increased airway resistance, where our PEEP inspiratory pressure will be very high. That can be seen due to conditions like either obstruction in the airway, bronchospasm, obstruction due to mucus plug. So these are the things that we have to note. Next, if we see an high peak inspiratory pressure and a high PEEP plateau, that would be due to decreased lung compliance. which could be seen in the conditions like ARDS, pneumothorax, interstitial pulmonary edema. So these are the reasons where we see a higher peak inspiratory pressure followed by an higher peak plateau pressure. Next, where pressure doesn't return to the baseline, there we should think of auto-PEEP, where there is air trapping. Generally, when we have an inspiratory phase and an expiratory phase, pressure should come back to the baseline. That is our normal. But if the waveform doesn't return to the baseline, then we have to think of condition that the patient is having generating an auto-PEEP, or there is air trapping, which can be seen in conditions like COPD and asthma. So these are the interpretations that we should think of while seeing a pressure time scalar. So next, coming to flow time scalar, gas flow in between the patient and the ventilator is basically represented by this flow time scalar. It basically has an inspiratory flow, which is usually above the baseline as seen here, and expiratory flow, which is seen below the baseline. The shape of the inspiratory flow depends on the mode of ventilation again, where in pressure control mode, the peak inspiratory pressure and the inspiratory time are set and the flow is variable. Hence, at the beginning of the breath, the flow is delivered at the highest rate as seen here, but then tapers off over the course of inspiration here as we see here. It results in a decelerating shape of the curve. So this is seen in pressure control mode. Where coming to the volume control mode, flow is constant until the goal tidal volume is achieved, resulting in a constant rise in the pressure and a higher PEEP, that is peak inspiratory pressure, but a lower mean airway pressure. Whereas seen in pressure control mode, patient has an higher mean airway pressure, which could be beneficial in situations like increased airway resistance. Next, coming to the expiratory flow, the shape of the expiratory limb of the curve is affected based on the airway resistance and compliance of the lung. In instance of higher airway resistance from some obstructive conditions, the flow scalar will show a decreased peak expiratory flow rate, and it will take a prolonged time for the curve to reach the baseline. The time taken to reach the baseline will be prolonged. Conversely, when the lung compliance is decreased, the peak expiratory flow rate is increased. Next, auto-PEEP can be identified on a flow scalar. Under normal condition, the expiratory limb touches the baseline as seen here. However, in conditions where patient is generating auto-PEEP, the expiratory limb doesn't touch the baseline where inspiration is already started. So in that condition, we can think that the patient is generating an auto-PEEP. Coming to the interpretations, what are the observation and what we must think in this condition? So if flow not returning to the zero before the next breath starts, we have to think of auto-PEEP, like I already told, and which will be seen in conditions like COPD or if the patient is severely tachypneic. Next is expiratory curve scooped or concave. We can think of conditions like obstruction seen in conditions like bronchospasm. Next, irregular inspiratory pattern can be seen in asynchrony or if the patient has self-effort. So in that condition, we have to think that the patient is fighting the ventilator. Next, coming to the volume time waveform, it is the graphical representation of the amount of gas delivered into the lung by the ventilator over the time. Here it has an inspiratory phase and an expiratory phase. Inspiratory and expiratory volume should be similar. And here, if there is a difference, it can indicate air leak in the system. In addition of showing this potential air leaks, the scalar can be used to evaluate the volume of patients, spontaneous breath, and the effect adjustment of the ventilator settings may have on the tidal volume. So this is the use of volume time scalar. So let's come to the interpretation, where if the volume not returning to the zero, then there is air leak in the system. And we have to think of conditions like cuff leak, tube leak, or circuit disconnection. Next, if the volume curve is lower than the expected tidal volume, then we could think of condition like restrictive conditions, or could be due to leak. So could be due to ARDS or pneumothorax. Next, if there is sudden drop in the volume, it could be due to disconnection or apnea, could be due to tube getting slipped or ventilator issues. So these are the things that we have to think while seeing for volume time scalar. So coming to the loops, I'll be discussing in the next video. So stay tuned for it.